everyone, and welcome to the Duke Center of Excellence in Manual and Manipulative Therapies Shop Talk. Today, I have the honor and privilege of having the man, the myth, the legend, Dr. Jason Silvernail, here with me to discuss his recent publication in Physical Therapy Journal. The title of the article is Orthopedic Manual Physical Therapy, a Modern Definition and Description. So, the views expressed in this Shop Talk session are those of the speakers, and they do not reflect those of the position or policy of the Department of Veteran Affairs, the United States Army, the Department of Defense, or the United States government. So now that we got the formalities out of the way, Jason, thank you for being here with us today. It's a privilege to be talking to you. Could you tell us a little bit about yourself, your current roles, your background?
Yeah, thanks, Damien. It's really great to be here. I'm excited to be able to talk with you about, and I'm super excited about the paper and the opportunities we have to bring this kind of information to people and help them better integrate this material and these concepts in their day-to-day practice. So my name is Jason Silvernail. I've been a physical therapist since 1997. I've been in the U.S. Army the whole time, where I currently hold the rank of colonel. I'm a senior executive military officer in the Army Medical Department as a commissioned officer and physical therapist. I've been in big facilities and small facilities. I've worked overseas, in and out of combat zones, both in the Middle East and in Afghanistan. I've worked in orthopedics and sports medicine and amputee care and trauma and some neuro rehab and just kind of a big wide scope that way. And I was also fortunate enough to be selected to attend the Army Baylor Doctoral Fellowship in Orthopedic Manual Therapy, where I got fellowship trained in manual therapy and really had a great experience there. And sort of subsequent to that, that's kind of what launched my interest in sort of manual therapy and in clinical reasoning systems that help us make better decisions on most things most of the time, and how powerful that can be for our patients. So I'm excited to be here to talk about
it. Awesome. You have quite the background there. Very impressive. So this paper, it's really a wonderful paper. Could you walk us through the history, the rationale? What led you to this project?
Well, I think that, there's the small story and the big one. And the small story is, my an important mentor of mine, Gail Dial, said, "Hey, this is a really important project, and I want to know if you will head it up." And like, when Gail asks you to do something, you don't say no. At least I don't say no. And so I think that's the small story. And I think the big story is that I think it has to do with the trajectory of how we think about clinical care and how we think about manual therapy sort of generally. So for me, at least, I kind of put this paper in sort of a longer timeline. I guess my perspective is a little bit wider than I think than maybe some other people's, and that may be part of what's really interesting about this. And so basically, we had a lot of very experienced manual and manipulative therapists from all sorts of different backgrounds and schools, and some of the biggest, other than me, some of the biggest names in physical therapy research contributed to this paper. And we all sort of got down and we sat down and we said, okay, when we think about, when we talk about, when we teach orthopedic manual physical therapy, or OMPT, what is it that we are doing? What is it? What does that mean to us? And we were surprised, I think, how similar it was. So I think a lot of times, I think in any profession, there can be a lot of different views about how we go about things, and that's perfectly okay. But I was surprised that no matter what their background was, no matter what the system or what the clinical reasoning method that they used, how similar we all were, and how similar we all saw what the process of orthopedic manual physical therapy looks like, and how it's helpful for patients, and how it helps clinicians make better decisions most of the time to help guide their patients in the right direction. And I think so. I guess that's the medium. So I guess I said short and long. I guess there's a short, medium, and long. And now for me, the long part about this, and something that I feel like I didn't really understand manual therapy well when I went to fellowship training. I mean, I had a sense that people who were graduates of this program had reputations of being outstanding clinician scientists, and that they really came out feeling a lot more confident and a lot more competent, both of those things, because I think we both know they're separate, right? They don't always go together. That feeling that sense of competency, and I remember treating patients knowing I felt like I was missing something. I wasn't able to help as many people as I thought I should be able to, and I was just looking for ways to be better. And sometimes I would talk to a patient, I would 3 or 4 visits in, and I just like, there's something about this I'm not understanding, and I don't know what I don't know. And so that's kind of what prompted me to pursue fellowship training. And as I think about, like, at least in the United States, the history of the American Academy of Orthopedic Manual Physical Therapists, or AOMPT, and how it connects to international bodies is it's a little bit interesting. Like, one of the things that really made physical therapy kind of get really big in the 70s is that we had a lot of very talented and skilled physical therapists, almost all of whom self-identified and practiced in a manual model, became very successful in the private practice world. And when you spend a lot of time examining patients with your hands and doing the kinds of physical exercise and the range of diagnoses that come into somebody who does orthopedic manual therapy, it prompts you to really push your knowledge base, not only in terms of its breadth of the different things that you can handle. I mean, it's not all just tendonitis and arthritis, right? And it also requires you to have a much bigger depth of understanding, especially in those high volume conditions or conditions that are difficult to treat for our patients. And when that happens over time, you develop a kind of diagnostic and treatment acumen and effectiveness with patients that has a way of getting around. And when that happens, and when enough people understand what that's about, that helps our patients see that there are options for their care that are not, a bottle of pills or an injection or a scalpel, and it gives them other options. So I think that the success of the manual model early on, with some early on in this, in this sort of evolution, is really a big piece of that puzzle. And I think for a long time, everyone associated manual therapy and hands-on care with all of those things. They associated it with clinical competence. They associated it with like a sort of clinical humility about the limits of what we can and can't know and can and can't do. And I think in the profession's eyes generally, whether you practice in this model or not, everybody kind of had an idea of what manual therapy was about, right? And that persisted for a while. And then, I don't want to lay everything at the feet of social media, but there's a lot of, but when there's more talk, and as the sort of the information, as information spreads, not through letters and calls, but actually through emails, and then through forum blogs, and then through other kinds of social media, more and more people were in that space talking about it. And while that was happening on the academic side, we were also having a much larger pressure for all of us in medicine, no matter what we do, to explain to stakeholders, including people who are paying for things and patients who expect to be helped, to explain and show evidence for what we do. And as those two things sort of were parallel and moving forward, we saw some people that, something that was a surprise to me, some people just don't like manual therapy. They don't like the people who do manual therapy. They are not the biggest fans of manual therapy in general. Maybe they've had a bad experience with manual therapy in the past, or with someone who was teaching them, or maybe it's just that they just don't feel like that has that they don't think that has a lot of value. And I'm not sure 100% why that is. But one of the things that I do think is that some people have associated in their minds manual therapy with, some less evidence-based approaches that other professions take who also do hands-on care, right? And there are other professions who do hands-on care that's similar to ours. I'm talking about more than one. And it had that kind of reputation with people. And so people started to think a little bit less of manual therapy, which is okay with me. But also they started to talk to students and people who were less experienced about that. And what I perceived, it was a very one-sided story about what manual care is and what manual therapy training was involved. And the things I was hearing from students, things I was hearing from professionals, from some of these folks, had nothing at all in common with anything I ever was taught or did in my manual therapy training. And so that was curious to me. And while that's happening, we have the other side, the academic side, talking. And as more and more, as I watch the systematic reviews come out, I watch the narrative reviews come out, I watch people talking about evidence, both in the lay press and in the academic world and at conferences. And I saw our struggle with understanding how to manage what people considered a multimodal intervention. So it's kind of easy on the medical side of things often. So we're going to give this people real medicine. We're going to give these folks an inert placebo. And the only thing we changed is one thing. That's just unimodal care, right? Let's study it and see if it's better. And I think that for the kinds of work we do in physical therapy, whether it's hands-on care or not, it's very much multiple modes of care or multiple mechanisms potentially happening at the same time, right? So there's the exercise portion, there's an education portion, there's the physical activities that we ask people to do, there's the hands-on care, there's the exercise therapy, there's the strength training, and so it's hard to kind of get your mind around all of these things and figure out which one of this group is really helping people. And I was surprised at many of the systematic reviews and clinical practice guidelines when they would look at something like that. They would look at a sort of a complicated intervention, and they would say, okay, well, this piece of it, it's got this piece of it, so we're going to pick it up and we're going to put it up and we're going to put it in that bucket right there, or we're not going to put it in this bucket right here. And what I found was interesting is that people will see a trial of orthopedic manual physical therapy, which anybody who's got training in orthopedic manual therapy, whether you're kind of from the entry-level PT up to somebody who's fellowship trained, it isn't just hands-on care. It's always education. It almost always has exercise therapy involved with it. It often has, advice about physical activities or how to stay healthy in your life in ways that are relevant to the disorder that we are treating. And so it isn't just one of those things. And it was interesting to see that some of those systematic reviews and clinical practice guidelines would say, okay, this is a really good trial and it's something that clearly helped our patients. But they did a manual therapy thing in it, so we're going to move it out. It can't be over here with the exercise therapy. We can't involve it there. Well, but we can't really put it. Let's lump it over here in this group. And I found that was interesting, but also kind of frustrating. Some of the best evidence that we have to manage common orthopedic problems for our patients has been shown to be effective. This model of orthopedic manual therapy, like knee osteoarthritis, is a perfect example. We have a series of randomized trials showing that method of care, OMPT for knee osteoarthritis, is superior to valid comparators. We started off with something like detuned ultrasound as a placebo, and it moved on to, comparing it to exercise therapy. And I found in reviews, and I also found in closed door discussions with some academic colleagues, a real bias against manual therapy. And when I say bias, I mean they were treating manual therapy trials differently without a good reason. Without a reason that scientifically made sense. It was merely the presence of manual therapy, right? And so I think in the manual therapy space, like we talk about bias a lot, about who's biased here or there. And I think all of those are healthy discussions. But I think it's important to sort of identify what we mean by that, right? And so they were treating trials that had manual therapy differently without a clear articulable reason other than the presence of manual therapy, right? And so while all of those things are going on, I realized that what we really need to do is find a way to tell the story and show the benefit of what we've already done in the literature in ways that will make sense to people now. And so when we talk about something being a modern definition and description, I think that's what it gets at. This paper, for me, it's exactly the stuff that was in my fellowship training that I did years ago, and it was exactly in the training that that Gail Dial or Carol Courtney did, many years ago when they did. Well, maybe not many. Sorry, Gail and Carol. But it isn't different. We just have to describe it and explain it in maybe a different way to help reach more people. So look, I know that's a lot of talking on my part, but I just wanted to kind of lay that out there, and that's really where I see the value of this paper overall in sort of the setting, both the setting of where it's how it's looked at professionally and how it's looked like academically and in the research evidence.
Absolutely, absolutely. And thank you for that. I think that touches on a lot of really important concepts that I wanted to discuss with you today, in this idea that you referred to this as a modern definition. And at one point in your article, you say that manual physical therapy, orthopedic manual physical therapy, I'm sorry, I should say, is not passive. And that's gotten some pushback in the social media world as well. We also go into differentiate orthopedic manual physical therapy from the application of a manual therapy technique itself. And I think you just did really well outlining some of those concepts for our listener and why you feel that way about it. So I think that's very, very helpful.
Could I talk a little more about the passive part now that you brought that up? Do you mind if I talk a little more about that?
Absolutely.
So one of the things I talked about was this a little bit of frustration of like seeing that it was seeing that manual therapy trials were treated differently, like for no clear reason. And one of the differences, or one of the false choices, I think, that has happened in the physical therapy space is around this issue of, we have these treatments over here that are active, and we have these treatments over here that are passive. And passive treatments are bad because they, I don't know, don't involve the patient, or it's not clear to me what the rationale is there, right? I mean, something either is helpful for patients or it's not. It's either acceptable by patients or it's not. It's either, based in good science or it isn't. And so I guess I don't fully understand where active and passive goes, but not only in some trials, but in conversations I had with academics, they would look at a trial, they would see a manual therapy technique and say, oh, that's passive care. I said, well, what about all this exercise we had people doing? Oh, well, it doesn't matter because you put your hands on them. Well, but I put my hands on them to examine them. Oh, well, that's different. That's not passive. That's part of the active approach. And I just was looking at them like, I'm not sure I get this. And so I know some of my colleagues have written an editorial about whether or not manual therapy is a passive treatment or not. I mean, I certainly don't believe that it is. When I'm caring for a patient, whether that's examination or treatment, there is a continuous process of feedback between me and that patient, both verbal and nonverbal, that requires me to adjust what I'm doing, and that requires me to change my decisions about what I do with that patient, on a sort of on a moment to moment basis, to be able to provide treatments that are well tolerated by the patient and that provide temporary, medium term, and then long term resolution for the impairments and disorders that they present to us with. And that sort of thing cannot be done in a passive sense, where we just say, okay, you lay there, I'm going to do this stuff to you, and I'm going to step away and say, okay, I did my passive thing to you. How do you feel now? Like there's nothing about that has anything to do with how I was trained as an OMPT. And so when I see descriptions of some people who have had like maybe not so good experiences in manual therapy training or with manual therapy, and it just doesn't seem to, it doesn't resonate with me. That isn't anything like what I learned or was taught. It's not anything like what I teach other people. And so I just think that an important part of the modern part of this is getting that perspective out too.
Absolutely. Absolutely. I agree. And I think that was really well said. And I think I always, hear the argument on the topic of, well, there's some manual therapists that practice this way. And my response is always, where are they? Because we know this has been the way that manual therapy has been taught for quite some time, is this idea that it's not just a passive treatment itself. So thank you for that. So
no, I mean,
Jason,
go ahead.
No, go ahead. Go ahead.
So I remember having this conversation shortly after our paper was published ahead of print. Perhaps I made the decision, or perhaps you could say it was the mistake of posting it on X, which I still think I'm actually required to say, formerly known as Twitter, where a lot of people talk about papers and that kind of stuff, and sometimes the discourse is pretty positive, and maybe other times not so much. And I had a colleague criticize what we were trying to do with this paper and say the problem is when you've got all these multimodal treatments that you do, one or two of them is working and some of the others are just free riding, or they're just free riding on the benefit of something else when you do too many different things with people. And that never really made sense to me. And I said it was a little bit like saying, okay, some people are, when they're sick, they feel better after they eat chicken soup. So should we give them some chicken soup with the carrots and without the carrots, just to make sure, because those carrots might be free riders. They just might be tagging along for and providing Nova. And how about the celery? I mean, let's be honest, Damien, nobody really likes celery, do they? Especially if there's not peanut butter involved, why are we eating celery? Clearly we can subtract celery from the chicken soup. And so like we could slice and dice these things a million different ways. But at the end of the day, we have this thing called chicken soup that comes in cans and that helps people feel better. Where's the problem exactly? Where's the problem? And so I guess I don't see a need to try to pull apart or to slice and dice this too much, especially when we are dealing with low cost, low risk, non-invasive healthcare that we know is cost efficient. I don't see that need. It seems like an unnecessary academic exercise, or again, it seems like bias. It seems like a differential treatment without good reason.
Absolutely. Absolutely. And I think, it's important for us to realize that these articles that you submit are highly critiqued by journals. And in this
Yes.
case, this was published in a highly reputable journal.
Yes.
We know it was reviewed by likely highly credible individuals before acceptance and publication. Do you think that the fact that this perspective was published in such a prestigious journal speaks to the importance of this work in the field?
Well, I hope so. I think that the review process was quite rigorous. We got a lot of great feedback from the reviewers that made the paper better. And we were challenged on a lot of what we said by the reviewers, and they challenged us to focus and make our arguments better and more and much more clear. And I think we did that. And I could add, in addition to being published in one of the most prestigious journals that our profession has, it's an editor's choice as well. So I hope that, I don't know if is there a gold star involved with that? I'm not sure, but I definitely think that should help. What I think it should do is that it should help an unbiased observer who maybe doesn't know that much about manual therapy. It should convey to them how important the editor and the reviewers of that journal think that their readers will benefit from that paper. I think that is definitely something that it should signal to them, and I hope that we're able to talk to more people about it and help maybe put to bed some of the unhelpful ideas people have about this that might be keeping them from using this effective method with their patients more often.
Absolutely, absolutely. Well, Jason, thank you very much for sharing your work. We highly recommend any of those of you watching that have not read the article, give it a read. I think the preprint version is still on PTJ, not the nice, pretty one, but I'm sure that'll be coming shortly here. Do you have any last comments for the listeners, Jason? Yeah, no, I do. One of the things that I'll say is that we pulled together a group of authors on this paper that represent a real diversity of how we teach and practice orthopedic manual therapy. So it doesn't reflect only one perspective or only one viewpoint or only one system of thought. And so I think that should add to an unbiased observer. I think that should add to the strength of the paper as well. And I hope more people take the time to think about how we classify and look at the evidence that we produce in the care of our patients to make sure that our patients are likely to get access to low cost, low risk, non-invasive care that in addition to being effective is cost effective for the healthcare system also. And I think that can only happen if we're being clear about ways in which we can best help our patients. Thank you. Perfect. Thank you again, Jason, for being here. To all the listeners, thank you for joining us. If you enjoyed this Shop Talk session, please visit the Center of Excellence in Manual and Manipulative Therapies website and explore some of the resources they have promoting credible information regarding manual therapies. That's it. Cheers.